Hello, this is session 3 for clinical decision making. Today we're going to talk about clinical reasoning errors. I think you'll find this one interesting because it's a lot about why we think the way that we do and why that is sometimes wrong. So, objectives for today, we're going to outline the steps of the clinical reasoning process, just how we go about making decisions. We're going to define cognitive dispositions to respond, CDRs, and we're going to talk about, what does that mean? We're going to talk about different cognitive dispositions to respond that we sometimes see when we're making diagnostic reasoning errors, and so kind of reasons why sometimes our thinking is not correct. We're also going to recognize clinical reasoning errors in common settings. We'll go through a lot of examples. And then, of course, the most important thing probably is we'll talk about ways that we can reduce clinical reasoning errors um, and like how can we make better decisions and avoid these errors. So this is this is not a test. This is like a fun little quiz that you get to do. So get ready. You could pause the video if you need to. Get a piece of paper. It doesn't have to be big, just a little piece of paper and a pencil. And there's going to be 7 questions. Give yourself about 10 seconds you don't have to turn this in. This is just more something that I think you'll find fun. Um, there's going to be 7 questions. Give yourself, after you've read the question, give yourself about 10 seconds to answer it. You can't spend like 30 seconds or a minute on an answer. These are supposed to be answered fairly quickly. You can also do this, let your family take this, or your brothers, sisters, anything like that, and you can see it's just a test on how we're thinking in different types of thinking. Okay, you ready? Okay. On a standard fire truck, there are 2 drivers up front, 1 at the rear, and 3 additional firefighters. So what is the total number of firefighters required for 5 standard trucks? I'm going to give you 10 seconds. Okay, time's up. In 2010, the average time required to complete a critical incident review, like to write a report, was 15.5 hours. How much time should be allowed for the 3 reviews that are expected next month? Okay, which of the following is correct? The Earth moves around the Sun or the Sun moves around the Earth? 10 seconds. Okay, a bat and a ball cost $1.10 in total. So together they cost $1.10. The bat costs $1 more than the ball. How much does the ball cost? Okay, if it takes 5 machines 5 minutes to make 5 widgets, or just widgets is just like any thing, any device, how long would it take 100 machines to make 100 widgets? It's a hard one, huh? In a lake, there is a patch of lily pads. Every day, the patch doubles in size. If it takes 48 days for the patch to cover the entire lake, how long would it take for the patch to cover half the lake? Okay, this is the last one. In a study, 1,000 people were tested. Among the participants, there were 5 engineers and 995 lawyers. Jack is a randomly chosen participant of the study. He's 36 years old. He is not married, and he is somewhat introverted, like he likes to spend time by himself. He likes to spend his free time reading science fiction and writing computer programs. So what is most likely? A. Jack is an engineer, or B. Jack is a lawyer. Okay. How'd you do? Um, get your answers. Here's the answers coming up. Okay, here's your answers. You can go back and check how you did. Um, the first three questions are a little bit more focused on the intuitive thinking system, or like the just, and then the last four questions are a little bit more focused on the reflective or the reasoning, or like the critical reasoning uh, type of reasoning. Hopefully, you didn't get them all wrong. Um, so in an ideal world, um, we would be making all of our decisions based on normative techniques. And when you think about normative, if you remember the earlier lecture, I think it was the first one, we talked. This is about where we use data and we use algorithms. We use like specific ways to make our decisions, evidence based. All the information is available um, along those lines. But in real life, most of the decisions that we make, there's a lot of different words for it, but here we'll say fast and frugal. And so frugal meaning you don't, normally we use that as a way to say that you don't spend a lot of money, like you're very careful with your money. So fast and frugal means it's like when we're talking to a patient, we're asking a few questions and ask her after just a few questions, a diagnosis kind of pops out of our subconscious mind even after we don't have much information. And this often is correct. Like a lot of times, after a few questions or just a minute with a patient, you can often be correct that that is the diagnosis. But often, even if we say that this is 90% or whatever, I don't have a specific statistics for you, but that's not good enough because we're talking about medicine. Like we're talking about things that could really hurt someone. We're talking about someone's health. Like so we need to be a lot closer to as close to 100% as possible because the decisions we're making are so important. I think it's a good thing to remember as doctors because a lot of times we'll get used to making these really important critical decisions that are affecting people's health, but you'll see a lot of doctors, it just doesn't seem like they've kind of forgotten that. They've forgotten the place that God has put them in the lives of other people. And I think most of you have heard me say this before, that this is a very unique position that God has put you in. It's these patients are going to be very sick and vulnerable and scared and have so many questions and not understand a lot of things, and they're coming to you to, in some instances, save their life. So I think we should just always remind ourselves of that, even as we get older and we practice medicine for many years. So we're going to talk about why are sometimes these, especially these fast and frugal decisions, why are they sometimes incorrect? Why are they sometimes wrong? If you were with me in class, I'd get a couple of you to give me some answers, but I'll give you a second. Do you have any ideas? Like, what would be things that would make those fast and frugal decisions wrong? Um, One thing is that maybe you just don't have the knowledge. Maybe you haven't seen this case before. Maybe you haven't read about this before. You didn't learn about it in medical school. obviously we can't teach you everything, and even after you practice for 50 years, like there's going to be certain things you haven't seen before. But really, a lot of times, um, these fast and frugal decisions, most of the time, if they are wrong, they're not wrong because of a problem with your knowledge. The most important one, um, the most common cause of these errors are reasoning errors. And that's what we're going to really talk about today in the lecture. Just the way of thinking about something, the way of arriving at a diagnosis, the way of um, thinking about what test to order, the process itself, that's your way of thinking was wrong rather than it actually being something you didn't know. So when researchers have studied these type of reasoning errors or cognitive errors, there's over 40 different types that have been described, and so we're going to talk about some of those. Um, but first, when we're talking about clinical reasoning, so it's a combination of things that we need. We need the knowledge, so we get this from medical school, we get this from residency, from reading books, all of that, to a skill, like a skill of like we teach in um, uh, our basic sciences courses of um, like our lab courses on standardized patients and teaching you about the OSCE and what type of questions you need to ask, what ways you need to examine. So we're giving you this, there's knowledge, but there's also the skills as you practice them, or maybe it's how to do um, a surgery or something like that. So there's skills involved. But there's also this big circle here about reasoning. Like we need to talk about how should we think, and what are the best ways that we should think when we're examining a patient or doing a surgery or something like that. So when we talk about clinical reasoning, we talk about it's the cognitive process necessary to evaluate and manage a medical problem. And that's just as important as the knowledge, if not more important, as the knowledge and the skills necessary. But a lot of times we focus on the skills and the knowledge, but we don't think about this. And this is really, when we don't focus on this, this is really why most of our errors are being caused by the way we're thinking. So when we think about a diagnostic process, what do you think about first? Like you think about, okay, you greet the patient, the introduction, you take a history, right? So in the first part, we're gathering the information, and then we come up with a differential diagnosis. Like we do the initial history, we maybe do part of a physical exam, and then we start thinking, okay, maybe this person has a viral URI, or maybe they have pneumonia, maybe they have these different things. Okay, I'm going to ask. So then we get to diagnosis refinement, and we think, okay, I'm going to make sure that this is actually a viral upper respiratory tract infection. I'm going to ask if they have any sick contacts. I'm going to ask if they have any bloody sputum or anything else that would make me think that it's not a viral upper respiratory tract infection. And then I'm going to refine my diagnosis. And so in all these processes, I'm gathering more information. But okay, now I'm going to refine it. So then I might be kind of go backwards and kind of say, okay, I'm going to change my differential diagnosis. Now I think it's more likely that it's a pneumonia, or I think it's more likely that it's an asthma. So then I ask a couple more questions about asthma, and then I think, okay, yeah, it is asthma. So then we kind of go down to the bottom, and we do a diagnosis verification. This might be if a lab test, this might be a specific or a chest x-ray to confirm that yes, it is a, a pneumonia, um, or this is COPD, or this is heart failure. And so we kind of like, but like if the x-ray shows that there's nothing there, maybe we go backwards again and we kind of ask some more questions, or order some more lab tests, or do some more physical exams. So this is a fluid process where we do start here and then go to refining it and getting it more really um, making sure we have it, and then at the verification process, we really establish that this is the diagnosis. But if it's not that, we go backwards or we go here, and hopefully at some point we end up here at the bottom. So that sounds like an easy process in some ways. So how well do we do? Just as doctors in general, are we doing a good job at going through this process? In one study, this is from Harvard in uh, the U.S., um, and this is so Harvard, as probably most of you know, I mean, it's probably the best university in the United States. Um, and so when we look at all the different insurance claims, like these are people that are unhappy with something that has been done, and they are suing the doctor or the hospital because of some problem that the patient thinks happened. And so out of all of these, patients have the most complaints about like a diagnostic error, like something where their diagnosis was either a, a wrong diagnosis was made, like they were told they just had a pneumonia and really they had lung cancer, or it was just delayed. Like at first, the doctor thought they had a pneumonia, and then doctor later found out that it was cancer, but it was 6 months later, and now the patient is going to die from the lung cancer. This is a higher percentage than errors that were done made during surgery, and then also medication errors where the patient was given the wrong medication, or obstetric errors where something happened. Um, the patient did not like something that happened during their delivery of their child. So when we look at this one, we're thinking, what are patients most thinking um, or most angry about? What are they suing doctors most about? It's mainly these diagnostic errors. And so when we do see medical errors, we know there's over 250,000 deaths per year that are due to medical errors, and that is just in the U.S. And there's a lot of different types of errors. We can group it in different ways. We can group it as a systematic problem, like a problem with the system, why an error was made, or an individual problem, like a problem, what was like a specific individual made an error. So if we go through a couple examples, like, so what if there's an understaffed hospital, like there's just not enough doctors or nurses at a hospital, and so some errors are being made because of that, versus what if a wrong dose of a medicine is given to a patient, the patient receives the wrong dose, or a wrong diagnosis is given to a patient. What do you think? Would these fall under systematic errors or individual errors? So for the understaffed hospital, that would be a systematic error. Like there's a problem in the system. Like we don't know why the hospital doesn't have enough doctors or nurses, but there's some problem with the system, and that is leading to errors. When we go to a wrong dose of a medicine, you might think that this is just an individual error because maybe the nurse just wrote it down wrong. And that could be true, but it could also be a systematic problem. Like maybe there's not a good system for the doctor to write down. Maybe he just writes the orders down on a little piece of paper, puts it in a stack of papers on a desk, and then the nurse gets it. And then so maybe just the system, maybe there's not a good system on how doctors are ordering medicines, or maybe there's not a good system on how the medicines are being delivered from the pharmacy to the nurse. So it could be an individual problem. It also could be a system problem. For the wrong diagnosis, that would be an individual problem because that would be like the doctor is just not, or I guess maybe there could be a systematic error too, but in general, this is going to be an individual problem where the doctor is talking with the patient, and for some reason he is coming to the wrong diagnosis, but normally that's an individual problem. So when we're thinking about these types of medical errors, like some of these errors, like we talked about here, it could be the doctor just cut the wrong thing in surgery, or a nurse gave the wrong medication. But these are really not as common as we're seeing as diagnostic or clinical reasoning errors. And so clinical reasoning errors, you could think about this as just an overall how the doctor is going to treat the patient, how is he going to manage the patient, whereas a diagnostic reasoning is more specifically, it could be kind of under clinical reasoning. Clinical reasoning could be any type of reasoning that was, or a clinical reasoning error would be any type of reasoning that was wrong during the whole medical stay of the patient in the clinic or in the hospital. Whereas a diagnostic reasoning are errors that are more specifically errors that caused the doctor to come to the wrong diagnosis. Also, there's, like we talked about before in the last lecture, decision making, and so there could just be a flaw in the way that a doctor is making his decisions. Like maybe he's not creating enough alternatives, or one of those steps that we talked about in the last lecture. And all of these are cognitive errors. It's not just that the pharmacy delivered the wrong medication. It's actually that like there was a problem with the way that the doctor or the nurse or whoever was thinking. So that first chart, this one here, is the amount of patients that are suing doctors or nurses, or the amount of complaints that they're making, about the amount of complaints that patients are making. But here, this is actually the number of cases that are getting settled where the doctor is losing and the patient is essentially winning a case, where the patient has come and sued the doctor or the hospital, and then the hospital or doctor has decided to pay that patient money and to help close the case. And we see here that the number of patients that are actually winning their cases in the court, it's way, way, way more likely that if the error was a diagnostic error, that the doctor is going to have to pay money, or that the hospital is going to have to pay money. And so although the number of complaints maybe between diagnostic errors and surgical errors are the same, it's really way higher when after the whole courts have decided on who was wrong and have come to a decision. It's a way higher likelihood if the error was a diagnostic error that the doctor or the hospital is going to have to pay. So this might be the doctor didn't take a good enough history, didn't do a good enough examination, he didn't perform some specific diagnostic tests, like taking cardiac enzymes or ordering an EKG or doing a head CT. Maybe a patient came in, sorry, maybe the patient came in with a headache and they didn't do a neurological exam. Maybe the radiologist misread the report of the, like was reading a head CT and didn't see that the patient had a stroke. So when we think about different factors that are contributing to diagnostic failures, we can think of there's certain things where it just happened. There was no fault. There's also, we can break them down into system-related errors, like there was a problem with the system, or there was a cognitive-related error on the on a nurse or a doctor, or maybe a combination of both. And we can see here that, okay, system errors have a big part, and so yes, we need to focus on how we can make our hospitals run better, our clinics run better, and decrease our systematic errors. But cognitive errors are very important as well. I mean, this is 72%. A cognitive error was part of the problem. Okay, and this is an interesting chart as well. This is going to be the chart that shows the most frequently missed diagnoses. Um, and you should know most of these by now. Pulmonary embolism, I know like the blood clot goes to the heart. Maybe this was misdiagnosed. Maybe it was misdiagnosed. Sometimes these patients just come in with mild symptoms with either chest pain or shortness of breath, and it's misdiagnosed. And this is obviously a very big deal because a pulmonary embolism can kill somebody. And you can just look down this list: a drug reaction, lung cancer, colon cancer. Often the colon cancer can be someone didn't do a rectal exam, so they missed a rectal cancer even though a colonoscopy was done, or they just thought it was hemorrhoids when really it was a cancer inside. Uh, Acute coronary syndrome, maybe like we're talking about a myocardial infarction here, where uh, the patient was just thought to have maybe a musculoskeletal problem. Um, I think this is a good list to know of. This is a good list to have in the back of your mind of when I'm thinking, am I missing anything in this patient? These are the type of, you don't need to memorize this list, but these are the type of diagnoses that are often missed and so are good to have in the back of our brain, just as things. Am I sure it's not this? Um, Even like depression, is on here. A lot of times, um, we might have a feeling this person seems a little depressed, but it takes a long time to talk to them about it, or I don't want to get there, or I don't want to have to deal with all this, and so a lot of times doctors just kind of ignore it. So the issue here is like we know all these different things. Like I'm sure I could ask most of you, what are the symptoms of congestive heart failure, and you would tell me some. But so why is it being missed so often? Um, it's not about our knowledge, it's about the way that we are coming to our diagnosis. So we need to know more about how do we think and why do we think that way. So hopefully we can change our way of thinking and improve on how we're making decisions. So this kind of brings us to the cognitive dispositions to respond. So what that means really is these two things right here. There's biases, and we'll talk about what that is, um, like reasons why we make a certain decision that might be wrong, and then also mental shortcuts. And there's a fancy word, heuristics. Um, this is just different ways that we might, uh, rather than thinking through all the different steps, we might jump some steps, and so we get to a diagnosis quicker. But by doing that, we might miss something. We can also break down, so just when we look at errors, like cognitive errors I'm talking about, or clinical decision errors, we can group them into different groups as well. And I mean, this is, I know a lot of you guys like to memorize these things, but I'd rather have you just think through it in a logical way. So this first one is just failure or delay of eliciting information. So we're talking about you're getting a history and you don't get all the information on your history or your exam. The second one is suboptimal weighing of critical pieces from the history and physical. And so maybe you've gotten all the information, but you're not placing enough value on one part, like you're not placing enough value on the bloody sputum, or you're not because you're more focused on something else that maybe is not as important. And then the next part is just over reliance on diagnostic testing. And so you're going to put most of your decision based on the the labs that you're ordering are an X-ray. Like a good example is for a pneumonia. A pneumonia really should be diagnosed on a physical examination. You should not need an X-ray to diagnose a pneumonia, because sometimes a pneumonia is not seen on an X-ray, or it's seen, but you should have been able to diagnose it on the exam. And so when we think about this in groups, like you didn't get enough information, you got versus number two, you got enough information, but you didn't focus on the right things. Or three, um, maybe, or maybe you didn't have all the information, but you just weren't even worried about that part. You were more thinking about the labs and the tests that you're going to order. So when we think of different errors as well, or these different cognitive dispositions to respond, so we can break it up into biases and mental shortcuts. And there's biases and mental shortcuts within these. Some of these are biases, some of these are mental shortcuts. Um, I don't care as much if you can say this one's a bias, this one's a mental shortcuts, and sometimes there's overlap between the two, but they're all different cognitive dispositions to respond. And so when we break these down into a different way, we can say there's sometimes the problem is how we're gathering our information. Sometimes it's a problem within the system, like the way of thinking, not just a systematic error like someone wrote something down wrong, like we were talking before. I'm talking now about a systemic error that was caused by a problem with the way the system in itself, or the group of doctors, or the hospital, all the people that were taking care of this patient, how all of them as a whole were thinking incorrectly. And also some probability errors, some errors of thinking that we just have a wrong way of thinking about the probability of a situation. So this will make more sense as we go through it. So when we're talking about information gathering errors, um, this uh, there's a lot, but we're going to focus on a few. And so one of those errors is unpack, and we'll go through examples of each of these, and I think it'll make more sense as we're going through the different examples. So one is unpacking, and so that is a failure. So it's like if you think of the patient as a piece of luggage or a suitcase, we're pulling out all the information from them. It could be from the history and the questions we ask, or a physical exam. So that's where we get the unpacking word. So we fail to elicit all the relevant information. So we didn't ask the right questions, or maybe we asked the right questions, but the patient didn't provide all the information that would have been helpful. Maybe they didn't think that information was important, so they just didn't share it. Availability, that means maybe we saw someone with uh, lung cancer recently, and that makes it either more or less likely for us to, it kind of influences our diagnosis now. Maybe we're more likely or less likely to diagnose someone with lung cancer because of we've been recently exposed to a certain diagnosis. Anchoring, uh, that is anchoring, like on a ship, like they put down their anchor, they put down like a big piece of metal um, to make it so the ship doesn't move um, when there's wind. And so this is where we're holding on to a diagnosis so tightly that even though we receive some contradictory information, we tend to minimize that contradictory information because we have already held on to that, we're holding on to that first diagnosis. Premature closure is close to that, but it's a little different. It's we we've kind of made up our mind what a diagnosis is before we've fully verified it. Like we maybe should have asked a few more questions, or done a certain physical exam, or like someone's sounding like from their history they're having pneumonia. We didn't examine their chest, something, or that we didn't order a lab test or something like that. Okay, so these are some examples. So this is my quiz for you. What type of information gathering problem would the following lead to? So if we have a 25-year-old patient with a cough, but he forgot to tell you that his brother also has a cough and a fever, what could that lead to? Look at this. So it's an unpacking error, right? We failed to elicit all the relevant information. Maybe it's because you didn't ask the question. Maybe it's because he just, for whatever reason, we didn't get all the information that we needed, all the relevant information that would have affected the diagnosis. What about you expect a 25-year-old patient with a cough, has a viral infection, and doesn't need antibiotics, even though he told you that he had some bloody sputum a couple days ago? What type of information gathering problem would the following lead to? So you have this patient, he has a cough, you think he has a viral infection, and that you think that he doesn't need antibiotics, but then, even though he told you that he had some bloody sputum a couple days ago. So this is anchoring because we're holding on to this diagnosis, even though, like, a person with a viral URI, they normally don't have bloody sputum. I mean, it is possible, but that is contradictory information. And even though you're you're still thinking this, even though he gave you contradictory information. Okay, a patient tells you he has a very sore throat and a fever, so you give him antibiotics for strep throat without examining his lymph nodes. You would never do this, right? Because we've talked about this in the clinical skills class. So what type of error might this lead to? So it's accepting the diagnosis before it's fully verified, right? It may be strep throat, but if you haven't examined his lymph nodes, that's really going to decrease the likelihood that you're right and increase the chance that you did an information gathering error. So last one, after seeing a patient with known hypothyroidism, another patient comes in complaining about fatigue. You focus your history on thyroid problems. So you have a patient with known hypothyroidism that you're examining, and then the next patient comes in and he's complaining about fatigue. And so you really focus your history on causes of or thyroid problems that might cause fatigue. So that is recent exposure influences diagnosis, and so that is an availability information gathering error. Okay, hope those make sense. If you have any questions, feel free to email me or send me a message on Microsoft Teams. So when we look at this original diagram, we're generating our original differential diagnosis, but if we haven't gotten all the information, or if we focus our history maybe too narrowly because of a certain case that we've seen recently or something along those lines, we're not gonna even generate the correct differential. We're not going to generate a broad differential. But then even if we have, say we've gotten everything, and we weren't very biased during this process, when we go to refine it, and we ask a few more questions, then the patient tells us something like, well, I do have a bloody sputum when I cough, but we still hang on to the viral illness diagnosis. That was a problem with anchoring. So it was a problem that happened during the refining stages of our diagnosis. And then premature closure, of course, it's towards the end. So okay, we've gone through this process, but then we just stop. And we don't even get to here. Like we have this patient that we have a sore throat, but we didn't verify it by either ordering a strep test or we didn't examine the lymph nodes, something like that. We just stopped. And so it was a premature closure. Systematic problems. And like I said, this is the problems with the way of thinking of the group of people that are taking care of the patient. So diagnosis momentum. Momentum is like when, it's hard to start pushing a car, but once you start pushing it, it tends to just keep rolling. So that's momentum. Or sometimes it's hard to start studying, but once you start, it's not as hard to keep going. So diagnosis momentum is a diagnosis is made by one provider, and then the other providers that see that patient accept that diagnosis as definite without considering other problems. Feedback sanction is a final diagnosis does not return to the initial decision maker. And maybe you can understand why that would be bad. The problem is that if that first diagnosis was wrong and the person doesn't, and then it ends up that so like a person has thinks it's a cough, the first doctor, but another doctor later finds out that this patient has cancer. It's nice if that information can be passed back to the first doctor so he can know how to better improve his way of thinking. But if that diagnosis is not returning to the initial decision maker, um, then um, then that can lead to this systematic problem of feedback sanction. Triage queuing is where diagnostic decisions are based on how a patient is first triaged. So like the patient comes into an ER, he appears a little bit sick versus very sick, or he looks like he's dying. Diagnostic decisions might be based off that. So this person didn't really seem very sick when he first came in, so the nurse triages him and says, okay, we're going to put him in the not very sick category. And so when a doctor comes and sees the patient, maybe he's less likely to give him a diagnosis of a serious problem because he was already thinking that this patient was not a very sick patient. So if we look at examples of this, an emergency doctor admits a patient with shortness of breath to the hospital. He's thinking at the time that the patient has an asthma exacerbation. The doctor seeing the patient the next day diagnoses the patient with a pneumonia, but the first ER doctor is never told about this finding. Which one is that? Okay, yeah, feedback sanction, right? Like the first doctor never heard about the final diagnosis that was made. Next one, a 50-year-old male patient describes his chest pain as very mild. An EKG done after 12 hours shows that he is having an acute MI. So what would, I have it written down for you. So this one is triage queuing, because an EKG for a person with chest pain should be done like immediately in the ER. And so it took way too long for this patient to have an EKG. Because the patient described his pain as very mild, there was a delay in the EKG, and it did later turn out that he had an MI, and so there was a big delay in his diagnosis. This can happen to, like if for a for maybe someone just thinking they're having like menstrual cramps, but it turns out to be something else. But if a patient often gets menstrual cramps, it can really make it hard to diagnose. You just automatically are going to think like, oh, this has got to be menstrual cramps. But it's important to think, oh no, it could be something else. Last one, an ER physician admits a patient to the hospital. The ER physician thinks the patient may be having an acute MI. A cardiologist sees the patient, orders a few more tests, and sends the patient home because he's pretty sure it's not an MI. The patient comes in 1 week later with a ruptured aorta. So what happened here? So here, we're thinking about diagnosis momentum, because the first diagnosis of a possible MI was really accepted as definite or most likely by the cardiologist, and the cardiologist didn't really think. He just focused on the MI. He thought, okay, this person does not have a MI or a heart attack, but he wasn't thinking about like a ruptured aorta or a dissecting aorta that might be happening because he was affected by the first diagnosis from the ER. Okay, now we're getting to the last group here. Probability pitfalls. Pitfalls are like errors or mistakes, something like that. You know, like a hofra fil ard and then wahed yuga fi. Um, okay, uh, aggregate bias. Um, this is where general data about a group um, is assumed to be true about an individual from that group. We'll go through examples too so it can make it a little more clear. Base rate neglect is where you ignore the true prevalence of a problem or a disease. So the prevalence or the amount of disease in a certain population is not taken into account. It's just ignored. Gender bias is where a gender, male, female, inappropriately colors the probability, meaning like we're more likely to diagnose something um, in a male or a female when we shouldn't be more likely to do that. Or at least we shouldn't to that same degree. So gambler's fallacy. Uh, fallacy is another word for like error or mistake. Um, a diagnosis is less likely to be seen repetitively. So if there's this game in gambling, roulette, where there's a black space and then a red space, a black space and then a red space, and they spin a ball around. And some people will say, oh, if there's been if the ball has landed on red 5 times in a row, the next time it's gotta be black, because what's the likelihood of it being 6 reds in a row? And this is actually an error, because every time, if you look at it from the beginning and say, what's the likelihood it will land on red 6 times? That's a correct way of thinking. Um, it's very rare. But every time, it's new odds. So, like for example, every time someone um, gets pregnant, it's a 50% chance it's going to be a boy and a 50% chance it's going to be a girl. It doesn't matter if the family has 3 boys, it's not more likely the next time to be a girl. Um, okay, post-year probability. It's like the opposite um, uh, of gambler's fallacy. It's saying, okay, if the ball has landed red on red 5 times in a row, it has to be red again, because that's what the ball is doing right now, when really the ball has no mind, and it's going to be 50% chance it would land on red and 50% chance it would land on black. So like when we're thinking about the baby example, um, this is a family that says, okay, we've had 3 boys. I guess we just make boy babies. And so next time it's more likely to be a boy because we have 3 boys already. When, of course, just like gambler's fallacy, that's not true, because every time is 50%. Okay, here's some different examples. Number 1, this patient can't have breast cancer because he is male, and males hardly ever get breast cancer. So that would be a gender bias, right? Like, okay, like it is less likely that males have breast cancer, but that doesn't mean that this patient can't have breast cancer. He definitely can have breast cancer. Even though it's less likely, it's definitely possible. Um, Next one. This patient is so young and healthy, so his chest pain can't be due to an MI. So this is aggregate bias. We're saying that out of people that are young and healthy, that's our group, they normally don't get heart attacks. So we're saying his chest pain can't be from that, when in fact it can be, um, because just because it's true about the group in general, it doesn't have to be true about an individual from that group. And this is really a a big one in racism in general, or just prejudices in any group. Like if we're going to say that um, all Palestinians, or just that Palestinians in general are smart, that doesn't mean that this Palestinian person that walks into my clinic it is smart. It's a very general one or whatever. But it could be anything like in America, there's a lot of race issues between black and white. Maybe a white person looks at a black person and says, oh, this person is, um, uh, or if there's a white person that thinks, oh, black people are more angry, um, then when a black patient comes in to his office, he's going to think, oh, this person's most likely angry, or that this person's an angry person, when in fact that's not true, um, because every individual is different. So um, things like racism and prejudices would really come under this. And it could be, this could be true data or it could be false data. Like for the example of the one I just gave, like it's not true that uh, black people are more angry or violent. But it doesn't, your bias here is about what you're thinking about a group, and then you're using what you're thinking to 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 make a decision about an individual. Another one is this after diagnosing two people for porphyria, um, which is a very rare disease, a doctor decides to test two more patients on the same day for porphyria. Um, what do you think happened here? Sometimes it can be multiple ones on the same answer too. But in general, I'd say this one is posterior probability. Um, and so this doctor is saying, um, uh, is thinking, because because of these other diagnoses, I bet these people also have this, or they're more likely to have this porphyria because I've been seeing it more lately. When in fact that's not true. Porphyria is a very rare disease, and just because he saw two patients with it doesn't mean he will continue to see patients with it. So it's probably a disease that you don't need to test for very often, especially normally not twice in the same day. Uh, Last one. People are surprised to hear that the likelihood of a positive COVID-19 test, and I'm talking about right now, um, where there is almost no community transmission of COVID in Jordan. But if people are surprised to hear that the likelihood of a positive COVID-19 test on an asymptomatic individual in Jordan is more likely to be a false positive, if people are surprised to hear that, then which of these are they um, uh, pitfalls or errors are they making? Base rate neglect. We're ignoring the true prevalence, because the truth is that the prevalence in Jordan is so low. It is so low that the false positive rate of the test is actually higher than the likelihood of a true positive, especially in an asymptomatic patient. Like an asymptomatic patient in Jordan has a very low likelihood of having a positive COVID-19 test. And so, but so it's actually um, in a country like America where there's a higher prevalence. Okay, it's more likely that it's actually a true positive. But in Jordan, it's more likely that it's going to be a false positive currently right now. So here's some other tests, and like I said, there are some other biases. Um, you don't need to know all these. I'm just kind of showing you how many there are. Like confirmatory biases, that's a tendency to search for or interpret new information in a way that one confirms someone's preconceptions and avoids information interpretations which contradicts the prior beliefs. And so, like when you're doing a study and you really think that uh, uh, that smoking uh, is going to lead to a decreased life expectancy. And so when you're doing the study, you're looking for ways to prove your point. And if in your study it shows that smoking does not decrease life expectancy, you're kind of going to ignore that part. Now we know that smoking does decrease life expectancy, but it's because of real data. It's not because of but we need to make sure we're not just assuming um, a data is going to say something, because we can sometimes force it to say something when it doesn't really say that. Illusory correlation, this is a phenomenon of seeing the relationship one expects in a data, even when no such relationship exists. This is very uh, uh, similar to the confirmatory basis. This would just say that, like, normally smoking and obesity goes together. Um, if we're thinking that is true, um, then we're going to see a relationship in the data more than is actually true. Representative or straight, this is something a diagnosis is ruled out because the presentation is not typical. Like if it's a really rare diagnosis, we're going to say, oh, it can't be this. Search satisfying, it's like very similar to the premature closure, where the search is called off when something is found, and so we're not like going to completion. As soon as we find something, okay, we stop. When really, maybe a patient has 2 problems or 3 problems or more. Hindsight bias, that's the idea where we look back and we say, that was predictable. We should have known that. When really there was no way we could have known that. Like if you're driving somewhere and you find yourself in traffic, you think, oh, I should have known it because on Mondays at 3 p.m. there's always traffic here. It's very easy to say that now, but it would have been hard to say that at the time. Over-pathologizing bias, a tendency to assume the presence of pathology. This is a tendency for doctors to give more antibiotics because they just assume like a patient is sick when they're coming in, when maybe the patient's not really sick at all. Maybe they just have allergies or something like that. But because the person is coming into their clinic, they are more likely to assume that there is a problem there when maybe there is, but maybe there's not. Overconfidence, the tendency to overestimate one's own abilities. And that's actually a really important one, because that is, doctors are famous for. We are very overly confident in our own abilities a lot of times. And so we're not as likely to ask other people for help or go read on our own. So if we talk about just the most common errors in general, if we're going to break them up into a different way, um, we're going to talk about context errors. This is inappropriately limiting consideration to only one set of diagnostic possibilities. For example, we're not going to consider GI causes in a patient presenting with chest pain, or maybe availability errors. We talked about this before, but now we're just talking about what is the 3 most common ones. We're going to choose the most likely diagnosis over rare conditions, and so patients with a dissecting aortic aneurysm instead has this chest pain attributed to musculoskeletal strain, because it's just more likely that the patient has musculoskeletal problem. But the problem is that we might miss, if we're always thinking that, there are some times where we're going to miss a dissecting aortic aneurysm. And then premature closure, that's where, just like we said, once a plausible condition is identified, other possibilities are just not fully considered, where ultimately we just stop thinking. And so this is where, uh, kind of like as we said before, where it's like the history gathering ones, where we're just not taking in all the considerations. Our possibilities are too narrow. Our differential diagnosis is too narrow. This is very common, um, where a doctor is just considering one diagnosis and not thinking, oh, it could possibly be these other things. Every time you're with a patient, you have to have at least three possibilities, if not 10, um, for availability. While most of the time you will be right, we always have to be thinking, what else could it be? Could it be something more rare? Premature closure. Even after we think we're right, we need to do the complete physical, complete exam, and order any tests that are necessary to make sure we're right. Okay, I know that's a lot of information and a lot of different terms, and I don't like to have you guys memorize too many different things. And so, just in general, when you're going through some of these, um, I want you to like get a picture in your head, or more of an example of these different types of errors and things. Like focus more on like the in general the general idea, Um, like gender makes sense, aggregate, that means like grouping. So if you know that aggregate means grouping, then you're going to know more that this is talking about data as part of a group that is now being applied to an individual. Gender is easy. Gambling, like you can remember this game. Posterior probability is just the opposite of that. Um, Triage, that makes sense. Feedback, the first doctor is not getting feedback. Momentum, the process is starting and it's not stopping. One diagnosis is being made, and then another diagnosis or another doctor is just assuming that one's right. Um, so just try to think about those kind of things rather than, I don't care as much about like if you can spit back to me the exact words. Like I want you to give me an example of a case, or when you see a case, know what kind of error is being made. Um, that's what's going to help you in your own thinking. So I think probably the most important of this lecture is really this last part where, okay, now that we know these errors, now we need to know how we can stop ourselves and stop the system from making these errors. And so one thing is getting feedback. And this feedback needs to be 360-degree regular feedback without intimidation. So 360 degrees means that uh, what normally happens is people get feedback about their job performance from their boss. Um, this is one direction, but a different direction they could be getting it from is from their colleagues, their other muwattafin, the other coworkers, um, the other workers there that are at the same level than them. They could also get it from uh, their patients or their customers. They could get feedback from. So it's important to get feedback from multiple different levels. Um, and this is not super common even in America, but in England it actually is more common, and in America it's becoming more common. And I know it's not very common in Jordan, but this is a huge way that we can learn, because maybe like our boss doesn't really know, doesn't see the our day-to-day decisions we're making, and maybe our coworkers do better. And so feedback is not so you can fire someone. The idea is that we're supposed to always be wanting to get better, and this takes humility, um, and uh, and just being willing to say, hey, how can I, like, you could either, this could be a formal thing, or this could be an informal thing where you just go and ask your coworkers or your patients or your employer, how do you think I could be better? And you don't have to take everything they say, but you should at least be willing to think about it. And that's really what's going to make you a better doctor, like, because you're going to continue to grow and you're going to continue to improve. Like, if someone's not very confident in themselves or is very prideful or, um, uh, shy of high-low. He's not going to listen to anybody else, and that is really going to make him a worse doctor. Um, but if someone is willing to listen um, and and listen to others and be with others, that's really going to make him a doctor. I love um, like certain stories about Isa in this way in the Injil because it talks so much about how he hangs out with poor people or uneducated people or the type of people that were less likely or like were people that a lot of the rich people or the very religious people they would look down on these poor people or these sick people. um, but Isa would sit with them and be friends with them and eat with them and talk with them. Um, and so he really was a good example of humility, and I think it's a good example to follow. It's We don't have to worry about our own image. Like we can leave that to God, and we can be willing to accept feedback from others. And in that way, we're actually going to become a better doctor, and that's going to be more helpful for future patients down the road. Um, this feedback as well should be regular. Um, I, it can, it can, if it's just randomly once every couple years, it's not enough to really be changing your practice. So this, I mean, should be every 6 months or something like that at least, or just even an ongoing feedback where patients can um, give feedback, or your boss or your coworkers, or just if any time. The best situation is when there's a culture that has been created at a workplace where people could correct someone else um, without that other person feeling like they're being attacked. Um, and that's a very difficult thing no matter where you live. Um, the other thing too is without intimidation. Like if a patient is going to be afraid that their doctor is not going to give them good medical care, they're not going to provide honest feedback. And the same thing too with other coworkers. They're not going to provide good feedback about their bosses, or they're not going to provide true feedback about their boss or about their other coworkers if if they're afraid of what's going to happen if they say the truth. So that's one thing is feedback, and we're not going to get into that too much here. But the other thing is metacognition, and that's understanding how we think and getting educated about possible biases that we have. And so that's really what we're talking about today. Is just we need to know what the biases are, and then we can think about, examine ourselves, and think, am I making any of my decisions based off of biases or cognition errors that I have? Understanding how we think, we're going to get into that a little more in the next lecture on really saying, like, how do we think? So, um, so final example we're going to run through. It's a 45-year-old woman comes to the emergency department with several hours of abdominal pain. She describes the pain as a burning sensation in her mid-abdomen. She points to the area just below her epigastrium, so kind of the upper, the kind of really middle of her abdomen. She took some antacids, which did not help, and she said, like Kals or Reni, something like that. It didn't help. She says the pain is like the pain she had when she had a peptic ulcer last year. So she kind of has an idea of what she thinks the pain is from. It's from this ulcer. Um, on exam, the vitals are normal, except for some tachycardia, and the epigastrium is not tender, and there are no masses. So her white blood cell count is normal, but her hemoglobin and hematocrit are significantly lower than they were a few months ago. So she's gotten a little bit anemic. So this is what a lot of doctors might do. They might say, the patient's probably right. I bet her ulcer is back. She should have continued to take her omeprazole like I prescribed to her before. But she seems stable enough now, so I'll admit her to a medicine ward. I'll follow her hematocrit since it is going down some. We'll restart the omeprazole, and I'll ask um, um, the GI doctor to see her, the gastro doctor to see her in the morning. Um, do you see any problems with this? Like one thing is okay, maybe that doctor is correct. Maybe it is the ulcer. But there's some things here that's a little bit weird. Like there's no pain when you press on her epigastrium. Um, the antacids didn't help at all. Um, so we need to think there's this uh, blood count that's dropping. Um, so this is maybe the type of more practice that I would love for us all to be doing, is that to say the patient is usually right. So that part's the same. I bet her ulcer is back. That's my number one diagnosis. And she should have stayed on her omeprazole, like um, her antacid, her PPI, or proton pump inhibitor that's going to prevent an ulcer from getting worse. So I'll admit her to a medicine ward and follow her hematocrit and restart the omeprazole and ask the GI folks to see her in the morning. But I wonder if there's anything else I should be thinking of. Is there anything else that I might be missing? Like right now, I only have one diagnosis, and Dr. Ben said I should always have at least 3, if not 10 diagnoses. So what about when I'm thinking about these things, what are some things I just can't afford to miss? Like when someone's having like pain in their uh, abdomen, um, what are some examples of things that I can't miss? And these are maybe some more questions that are more specific, because these are good and these are 2 important questions. But what about just more specifically, if we're talking about some of the errors that we were talking about today, like, am I making my mind up too early? Like, hold on, am I making my mind up too early? Should I be still thinking a little bit harder about this? Am I missing something because she seems young and healthy and female? Like, is that biasing me? Is her diagnosis of the problem affecting mine? Like, she kind of has an idea of what it is. She thinks it's an ulcer. Is that affecting my diagnosis or my thinking? What about, is there anything that I forgot to ask? Like, is there anything else? And why doesn't she have pain when I push on her epigastrium? Um, so when we think about these questions, what are these questions addressing? Like, what type of errors are they trying to avoid? So, for example, like, am I making up my mind too early? If we are making up our mind too early, that's an example of a premature closure error. And so we're asking this question to try to avoid that error. And am I missing something because she seems young and healthy and female? Remember, that's the aggregate bias, um, uh, where she's taking this type of uh, um, taking this group in general, a young, healthy female, and we're saying that um, maybe we're not thinking about a certain issue because of that. Um, I, or this could even that question falls under the gender bias. So like I said, sometimes it's multiple different things. So because she's a female, is that influencing my diagnosis inappropriately or too strongly? Uh, Also, is her diagnosis of the problem affecting mine? Do you remember that one at all? That was the diagnosis momentum, where okay, she's thinking about a certain diagnosis. Is Am I coming to that diagnosis more quickly because she has that diagnosis inappropriately, and that's diagnosis momentum? Is there anything else I forgot to ask? So we're talking about the information gathering. This was the unpacking, an unpacking error where we just like didn't ask all the right questions or didn't get enough of the answer or didn't get enough information. So maybe we made an unpacking error, like we didn't get all the information. And why doesn't she have pain when I push on her epigastrium? That's an important question to ask because normally if someone has an ulcer, they will have that. So now we have some information that is um, uh, contradictory to our diagnosis, but we're still holistic even despite that new information. And so that's an anchoring error. And so if we are asking this question, we're trying to overcome anchoring errors, where we're holding on to the diagnosis despite having contradictory information. And then, okay, so maybe after we go through theirs, we think, maybe I should also be thinking of some like other things that could be going on. Maybe a problem in her heart that's referring pain to the abdomen, or maybe uh, uh, some a liver problem or a pancreatic problem or appendicitis or something else. Um, so maybe we order an EKG, maybe we order some cardiac enzymes, a liver and pancreas lab test. Maybe we order a CAT scan of the abdomen before she leaves the ER, just to make sure her pain isn't from something else. So the next morning, the standard practice, you might get there, and you might say, "What? She's unresponsive? Like she's in a coma? Her blood pressure is 80 over 40? Call the surgeons and call my lawyer because I am for sure getting sued." The reflective practice, like if you've kind of thought through everything, um, you're going to say, wow, I'm really glad I stopped for a minute and I ordered that EKG and cardiac enzymes. Because even though it wasn't typical chest pain, like she was having pain that wasn't being explained fully by my diagnosis. So I'm really glad I thought about other things. Um, and so because we ended up diagnosing her with MI, she went to the cardiac cath lab that night, and she's doing well and didn't go into a coma like the standard practice. Um, okay, for your homework for this lesson, um, there are some, uh, there's two different forms um, on on OneDrive that I would like you to fill out and send to me. I don't think it'll take you too long. This one is a little longer than the other homework. They're going to look like this. There's two different handouts. This is the second one, and this is the first one. So we're going to list 3 causes of abdominal pain that are more likely in a 20-year-old than a 60-year-old, and which one is the most likely. And so you just fill that one out and fill this one out and go ahead and send it to me within a week. You can send it to me via Microsoft Teams, or you can just email me at my email, bencolton5@gmail.com. Hopefully, if we can get Microsoft Teams up, I'm hoping it's up today, we can do everything on Microsoft Teams because it's easier to see. And if you have any questions, feel free to let me know. And thank you very much for listening.